Hello students. So now let's discuss the topic on antepartum hemorrhage. Antepartum hemorrhage basically means the bleeding that is occurring in the pregnancy once the fetus has crossed viability. So after the viability has been crossed, the bleeding that is happening is antepartum hemorrhage. There are various causes of antepartum hemorrhage. So the bleeding can be either maternal causes, that is basically those related to placenta specifically. Next, it could be fetal causes or due to local causes. The maternal causes include Placenta Previa Abruptio Placenta as well as placental anomalies. There are some placental anomalies which can lead to bleeding as well, such as circummarginate placenta as well as circumvallate placenta. These are few of the conditions that can lead to antepartum hemorrhage. Among fetal causes, this includes vasa previa. It could be due to vasa previa. Local causes such as polyp, erosion, and maybe even cervical growth such as cervical cancer are some of the causes. Among these, what is the most common cause of antepartum hemorrhage? The most common cause of antepartum hemorrhage is Abruptio Placenta, which constitute 1 in 200 pregnancies. It is 1 in 200, which is closely followed by Placenta Previa, which is 1 in 300 pregnancies. Most common cause, Abruptio Placenta. Second common cause, Placenta Previa. So, we would be discussing mainly about these two conditions today. So, first of all, what is Placenta Previa? So, Placenta Previa means basically the placenta is not occupying the normal location of placenta. So, whenever the placenta is occupying the lower uterine segment, it is known as Placenta Previa. There are various classifications that are used for Placenta Previa. And this is the Brownies classification. This is Brownies classification. This is the older classification, but still you must be aware of the types of placenta and how it is divided in this classification, and sometimes question can come from this. So basically in this, it has been divided as 1 to 4 and each of this is subdivided as A and B. So let's see them one by one. So in all of these conditions, the placenta is going to occupy the lower uterine segment. But apart from that, in type 1, it is occupying the lower uterine segment. You can see till here is the lower uterine segment. It is occupying the lower uterine segment, but it is not reaching the internal os. Here is a cross-sectional view. Here you can see the internal os and the surrounding area is the region of the lower uterine segment. So, the placenta is not reaching up to the internal os. In the next one, the placenta is reaching up to the internal os, but it is not covering the internal os. It is just touching. It is just touching the internal os. Whereas in type 3, it is covering over the internal os, but not when the cervix is fully dilated. Suppose this is the internal os is here. The placenta is occupying till the internal os, but once the cervix is dilated, it is not covering the internal os. Type 4, you might be clear of it now. It is complete placenta previa, in which it is covering over the internal os and even when the cervix is dilated. So, this is type 3. The os are covered but not when fully dilated. Here, it is completely covered. So, it can be also called as type 1. Sometimes is referred to as low-lying. Type 2 is also known as marginal. Type 3 is also known as partial placenta previa. This is complete placenta previa. Again, each of these types has been subdivided as A and B depending on the location of placenta. If the placenta is anterior, then it is A. If the placenta is posterior, then it is B. Alright. Among all these types, type 1 to A are considered as minor degree of placenta. They are considered as minor degree of placenta previa, whereas 2B to 4 are major degree of placenta previa. Now, let's see what is the newer classification. So, in the newer classification, they have removed all these, that is 1, 2, 3 and 4. It is just divided into 2. Either it is low-lying placenta or it is placenta previa. Either it is low-lying placenta or it is placenta previa. Low-lying placenta means the placenta is within 2 centimeter of the internal os. So, let's have a look here. So, this is the internal os and suppose this is till the 2 centimeter cutoff. So, this is the 2 centimeter cutoff. This is just a schematic representation. So, in the first diagram, you see that the placenta, lower border of placenta is not within the 2 centimeter of internal os. This is normal placenta. In the second one, it is within 2 centimeter of the internal os, but it is not covering the os or it's not covering the cervix. That is low-lying placenta, less than 2 centimeter from the cervix, but not covering the internal os. In the third one, it is completely covering the cervix and the internal os. It is completely covering. That is placenta previa. So, these are the two types. Alright. Now, coming to the risk factors. Now, let's discuss the risk factors of placenta previa. So, the risk factors include previous history of placenta previa. As I usually tell you, whenever in OBS, usually the previous history is again a risk factor for the condition to recur in this pregnancy. So, previous history of placenta previa is a risk factor. Increased maternal age and parity is a risk factor. The higher the parity, higher the age, more is the risk for placenta previa. Please remember that whenever the size of the placenta is small, conditions in which the size of the placenta is more, there is more chance that it is going to occupy the lower uterine segment. So, from this, you can remember a lot of causes. This include conditions such as smoking. In smoking, there is hypoxia. So, as to compensate this, there is compensatory placentomegaly. So, in women who are smoking, and also bigger placentas are seen in case of multiple pregnancy. So, in multiple pregnancy as well, there is more chance. Whenever there is a placental anomaly such as when there is a subcenturiate lobe or a bilobate placenta. I have taught in detail about this in the topic of placenta. But when there is another successive lobe, when there is a smaller lobe, that is subcenturiate lobe, or when there is two lobes, placenta bilobata, they again increases the risk of placenta previa. Let me write it down. Bilobata, placenta bilobata and subcenturiate placenta are going to increase the risk. Alright. Any uterine anomalies will also increase the risk. Placental anomaly as well as uterine anomaly are going to increase the risk. Placental anomaly as well as uterine anomaly are going to increase the risk. Alright. ART such as IVF. Another important risk factor is previous cesarean section. More the number of previous cesarean section, there is higher chance of placenta previa. There is chance that this placenta will implant or attach to the previous scar. So, there is more chance of placenta previa. You should be aware of all these risk factors. Alright. Now, what is placental migration? So, placental migration means that initially in 90% of the cases in which we see placenta to be low-lying or occupying the lower uterine segment, 90% of them are going to migrate. So, in the initial pregnancy, while we do a scan, maybe the anomaly scan is done and we found that the patient is having low-lying placenta or placenta previa. The patient is having placenta in the lower uterine segment at 20-week scan. Alright. In these women, in 90% of the women, the placenta is going to migrate upwards and they will convert into a normal placenta by the time they reach term. So, in 90% at term, it will migrate and be normal. It will migrate and they will become normal. Whereas, in 10% of the cases, in 10% there will be persistent placenta previa. 10% there is going to be persistent placenta previa. Alright, what is meant by migration? Migration does not mean that placenta is going to walk and go upwards. No, this migration is basically due to the differential growth of the uterus. So, initially we have a small choto uterus, lower uterine segment which is small, and in this choto uterus when the placenta is going to form, most likely there will be some form of attachment to the lower uterine segment in many of the cases. But when there is growth of the uterus, you know that the uterine size is going to increase. The lower uterine segment is going to form. So there is differential growth of the uterus. The upper segment as well as the lower uterine segment is going to form and develop. When this differential growth of uterus happens, this will lead to placental migration, and placental migration is going to happen in 90% of the women, but in 10% it is going to remain. So what are we going to do about it? So this is something that very commonly happens in the OPD. So some patient come to me by 20-week scan, which is showing that placenta previa, and by the time she might have searched everything about placenta previa in the YouTube, and she would be so anxious about the complications. So I try to reassure her. I tell her that out of 10 women, 9 of these cases are going to be normal. Out of 100 women, 90 of them will have a normal placenta by the time of delivery. But there is a chance that 10% can remain. 1 out of 10 women will still have this complication. So what are we going to do for that? So I tell her that we will be doing subsequent scans and see where the placenta is. So we will be doing a scan at 32 weeks, and mostly it might have migrated by then. If it has not, I will be again repeating the scan at 36 weeks. So this is again the answer for this as well. So for a patient who is having a placenta previa or placenta that is occupying the lower uterine segment by the time of 20 weeks, what are you going to do? So you are going to again repeat the scan. You will repeat the scan at 32 weeks. You are going to repeat the scan at 32 weeks. Then again repeat the scan at 36 weeks. By the time, if still she is having placenta previa or low-lying placenta, we have to manage her accordingly. This patients in which it is persisting, this is the 10% which I mentioned about. So let me ask you one thing. Which is the best time for placental localization? This is a previous question as well. So which is the best time for placental localization? Is it the first trimester, second trimester, or the third trimester? It is the third trimester. So the best time for placental localization is the third trimester. Alright. Now let's discuss about the clinical features of placenta previa. So let me make this easy for you. Just remember it with 3 P's. It's mostly P's. So what are these P's? 1 P is for painless. There is going to be bleeding in placenta previa, and this bleeding is going to be painless bleeding. Next P is profuse. The amount of bleeding is going to be profuse. The bleeding is profuse. And usually the symptoms are proportionate to the blood loss. The symptoms such as pallor is proportionate to the blood loss. So in this same session, I am going to tell you one more condition in which the pallor is not proportionate to blood loss. We will come to that soon. Alright. Again, another thing is the bleeding in placenta previa is inevitable. The bleeding is inevitable bleeding or unavoidable bleeding. That means that the bleeding is definitely going to happen, because you know that the placenta is going to attach to the lower uterine segment, and this is an inelastic part. So as the uterus grows gradually, the lower uterine segment, which is inelastic, and the placenta is also going to grow, there is chance that it will slightly start separating from the attachment of the uterus. So the bleeding is inevitable. Alright. And the bleeding is usually causeless. There is no precipitating factor or any cause. It is usually causeless bleeding. And there is something called warning hemorrhages. Initially, there is small bouts of bleeding or minor bleeding happens. Then after some time, the patient starts having profuse bleeding. So basically, this bleeding is warning us that a major bleeding is about to happen. So the two characteristics are, it is an inevitable or unavoidable bleeding, and warning hemorrhages are seen. Alright. So all of you make a table in which first we would be writing all about placenta previa, and once the topic of abruption comes, you can fill the second part of this. Alright. So in placenta previa, as I told you, it is the 3 P's. It includes the painless bleeding which is profuse and it is proportionate. What is proportionate? The clinical features, the pallor are proportionate to the blood loss. The bleeding that is seen in placenta previa is fresh and bright red in color. It is fresh bleeding or bright red in color. So, while you do an examination, you will find that the tone of the uterus is normal. So, the uterus is relaxed or the tone is normal. Relaxed uterus. When you check the fundal height, it can either correspond to the fundal height or sometimes be lower than the fundal height. Why is it so? So, let's first write that down. So, fundal height either corresponds to period of gestation or it is lower than period of gestation. So, here the placenta is basically occupying the lower uterine segment. So, the fetus is unable to be in the normal longitudinal lie, that is cephalic as well as in the longitudinal lie. Sometimes there can be associated malpresentations along with it. So, what is the complication that is seen? There can be malpresentations. And in these malpresentation, if the fetus is in transverse lie, the fundal height might appear less than the period of gestation. That happens in transverse lie. Fundal height is less than period of gestation in case of transverse lie, which is quite common in case of placenta previa. While we check the fetal heart rate is usually present and normal in case of placenta previa, unless there is an excessive bleeding and in later stages. Usually, the fetal heart rate is present and there is less distress. Now, coming to the examination. So, suppose a patient has come to you with antepartum hemorrhage. She is currently 30 weeks. So, you have examined her, you found all these findings. And what are you going to do next? Will you do a per-vaginal examination in this patient? Per-vaginal examination is actually never done. It's a criminal offense so as to do a per-vaginal examination in a patient of placenta previa. So, never do a per-vaginal examination in a case of antepartum hemorrhage. Before doing a per-vaginal examination, you have to check her previous scans, whether there is any placenta previa previously. First, you will check the scans. In case if no scans are available, then you will do a per speculum examination. Only a per speculum examination has to be done. Only after ruling out placenta previa, you can do a per-vaginal examination. This can very well come as a clinical scenario for you in which they ask, there is an antenatal patient who comes with bleeding, there is no ultrasound available with her. Now, what are you going to do next? There would be per-vaginal examination, per-speculum examination and so on. Never choose per-vaginal examination. Do a per-speculum examination and rule out. Only then you can go for a per-vaginal examination. Alright. So, the local examination that is performed is the per speculum examination. Never ever go for PV examination in case of placenta previa. Very important point. Alright. So, what is the next investigation that you are going to do? So, the next investigation that you are going to do is going to be a transabdominal scan. So, the next investigation, basically you do a TAS scan to see if the placenta is low-lying. But the problem is that mostly we are not able to say for sure whether it is low-lying or not, whether there is placenta previa or not. For better assessment, the best test, if they ask you the best test or the investigation of choice, it is transvaginal sonography. Now, many of you might have a doubt. Won't transvaginal sonography cause bleeding in such patients? No. Transvaginal sonography, the probe is going to stay to at least 2 centimeters short of the cervix. We are not going inside, unlike while we do a per-vaginal examination. So, TVS can be done in case of placenta previa. Please have a note of that, and it is the investigation of choice. Now, coming to the management. So, this was the investigation of choice. Now, coming to the management. So, the management of placenta previa is basically conservative management. So, initially I told you the patient is going to have intermittent bleeding. There is going to be warning bleeding and she will have bleeding again and again, but the fetal distress does not happen very early. So, here we are going to follow a conservative management. There are some indications in which we can follow a conservative management. There are some indications where we go for a definitive management, that is surgery. I will tell you that in a short while. But now you understand that there are two forms of management. One is the conservative management and the other is the definitive management. So, the conservative management is also known as McAfee and Johnson's regimen. So, the conservative management is also known as McAfee and Johnson's regimen. What is this? So, in this, when an antenatal patient comes, basically with bleeding, who is a case of placenta previa, we admit the patient. We admit the patient, monitor her. We monitor whether she is having bleeding, how her vitals are. We monitor her continuously. Along with that, we make all arrangements. We will arrange blood for her. There should be all facilities for an emergency cesarean section. If at all the bleeding goes out of hand, we will have to go for a cesarean section. If there is fetal distress, we will have to go for a cesarean section. So, we make everything ready and we watch how the patient is doing. This is mainly because we don't want to terminate very early. Because if we terminate very early, there is going to be prematurity. The baby is going to be premature. If we wait for too long, there is a possibility that mother is having bleeding. So, we are balancing out these two. So, in conservative management, basically, we wait and watch. We see if there is any bleeding, how she is doing. But at the same time, we make everything ready. If at all she has any complication, we will go for cesarean section. Yes, and cesarean section is the definitive treatment. Alright. This is basically about the McAfee and Johnson's regimen. So, I told you that there are two forms of management. One is the conservative management and other you have the definitive management in which you terminate the pregnancy. So, what are the indications when we go for conservative as well as for definitive management? So, conservative management is done only if the mother as well as the baby is stable. The mother and the baby is stable. You have to understand that basically we are doing this conservative management for the fetus. So, once the fetus is term, there is no point of again waiting. There is no point of conservative management. So, this is done only up to 34 weeks, or we can write it as conservative management is done in a pregnancy which is less than 37 weeks. Apart from this, the mother has to be stable. That is, mother is hemodynamically stable. There is no excessive bleeding. So, light amount of bleeding, we will wait. But if there is profuse bleeding, we are not going to wait. There is not excessive bleeding. Excessive bleeding should not be there. The third is the fetus is stable. So, here mother is stable, next fetus is stable. That is, there is no fetal distress. Finally, the patient should not be in labor. If she is in labor, now there is no point of waiting. Finally, if she is in labor. If she is in labor, there is no point of waiting. So, finally, if she is in labor, you are not going to do conservative management. So, here the indication should be she is not in labor. She is not in labor. So, now the definitive management is very easy. Anything which is not this, that is, the period of gestation is more than or equal to 37 weeks. The mother is hemodynamically unstable or unstable. There is excessive bleeding. There is fetal distress, or if there is intrauterine death. If there is already intrauterine death, what is the point of waiting now? Or if she is in labor. These are the indications. This is extremely important. They can frame a lot of clinical scenarios by giving any of these points and ask you what type of management you are going to go for. Suppose, let's assume a patient is there who is having placenta previa. She is 34 weeks. She is only having minor bleeding. But in that case, they also gave that there is an ultrasound scan in which the fetus has already died. There is intrauterine death. Will you go for conservative management now? No, you are going to go for definitive management. or the patient is having excessive bleeding, she is hemodynamically unstable, will you go for conservative management? No, you are going to go for a definitive management, especially in the next based exam in which they are analyzing the analytic skills. This is very important. All right. Now, briefly discussing about the conservative management, which I told you about. What do we do? It is known as McAfee and Johnson's regimen. So, this basically involves we admit the patient, we arrange blood for her, we monitor her vitals, we watch for any bleeding, and she is RH negative. If she is RH negative, we have to give her anti-D as well. And if the pregnancy is less than 34 weeks, you will give her steroid. You will give her steroid coverage for the fetal length maturity. These are the basic steps that we follow in the conservative management. So, coming to the definitive management is basically termination of pregnancy. We are going to deliver the patient. So, the options of delivery are either a cesarean section or a vaginal delivery. So, in placenta previa, mostly the dictum of delivery is by cesarean section, except in a few cases. Except in few cases, the dictum is for going for a cesarean section. Let's see that. So, there are two options, cesarean section as well as vaginal delivery. As per the previous classification, we go for a vaginal delivery in case of a placenta previa which is either 1 or 2A. 1 or 2A. From 2B to 4, that is the major placenta which I told you about. Major types of placenta previa. In that, we go for cesarean section. This is as per the older Brownies classification. Alright. As per the newer classification, when there is a low-lying placenta, that is, it is within 2 cm of the internal os, but it is not within 1 cm. So, let me draw it here. So, this is the 1 cm cutoff and this is 2 cm. So, if the placenta is within 2 cm of the internal os but more than 1 cm, that is the placenta is coming here. That is the only situation where you can go for a vaginal delivery. Whenever the placenta is within 1 cm of internal os, this diameter within 1 cm, that is either it is within 1 cm, it is touching the internal os, it is covering the internal os, whatever be the scenario that they give you, go for cesarean section. So, in the previous classification, it is only for 1 and 2A. In the newer classification, it is only between 1 to 2 cm from the internal os. Less than 1, touching the os, covering the os, always go for cesarean section. Alright. Now, coming to the timing of delivery. When do we deliver this patient? So, if everything goes fine, the patient is not having any bleeding, she is perfectly fine, you just saw a placenta previa in the scan that you had done, then you can take her till 37 weeks. Or she is having very minor bleeding only. But if the question is giving you, she is having recurrent episodes of bleeding, she is bleeding again and again, in that case, only go till 34 weeks. It is depending on the scenario. So, the timing of placenta previa, if everything goes fine, there is no bleeding, just the placenta previa, you can go till 37 weeks. If there is recurrent bleeding, if she is being conservatively managed with recurrent bouts of bleeding, go for delivery at 34 weeks. If in between this time, if there is any complication, you are going to go for immediate delivery. Immediate delivery. So, what are the timing? If everything goes well, there is no bleeding, no problem at all, go till 37 weeks. If there is recurrent bleeding, go till 34 weeks. If there is any complication such as maybe fetal distress or the mother is unstable or she went into labor, go for an immediate delivery. Alright. I hope that simplifies how we are managing the placenta previa. Alright. So, now let's have a look at this. So, what is the sign that is described here? So, you see that there is fetal bradycardia on pressing the fetal head down into the pelvis. When you press the fetal head, there is bradycardia, and once you release the pressure, the bradycardia is also going. This is known as Stalworthy sign. This is known as Stalworthy sign. This is known as Stalworthy sign. And this is seen in case of posterior placenta previa. This is basically seen in case of posterior placenta previa. And why does this happen? This is due to cord compression. It is due to compression of the cord. Where is it seen? It is seen in posterior placenta previa. Alright, so now we have learned about placenta previa. Now let's discuss about placental abruption. So what is meant by placental abruption? Abruption basically means that there is premature separation of a normally located placenta. If you remember this, you get all the points of abruption. 1. There is premature separation. The separation normally happens during the labor. So no, it is happening before that, before the labor. So there is premature separation. Second is of a normally located placenta. That means by this we are ruling out placenta previa as well. So it's the premature separation of a normally located placenta. And which is the most common cause of antepartum hemorrhage? That is placental abruption. The incidence is 1 in 200. So, Abruptio Placentae is also known as accidental hemorrhage. Sometimes the question can give you accidental hemorrhage. Please understand that it is one and the same. So, basically in this, there is separation of the placenta from the placental bed. And once the separation happens, there is going to be breakage of the spiral arteries. I taught you about the placenta. If this is the basal layer, decidua basalis, we have the spiral arteries which are supplying here. So, once the placenta separates, there is going to be rupture of the spiral arteries and this is going to bleed into the bed of decidua basalis. So, this will lead to hematoma formation there. Alright. So, there is rupture of spiral artery into decidua basalis. So, this is the most common cause of antepartum hemorrhage. Apart from that, abruption is the most common cause of DIC or conceptive coagulopathy as well. Conceptive coagulopathy as well. So, in abruption, there is more chance of complication to happen early, such as there is early fetal distress, there is early development of complications such as DIC. So, understand that the complications happen early in Abruptio Placentae. Now, let's see the types of placenta previa. So, the types can be either concealed or revealed. Either the blood can collect behind the placenta itself. This is known as concealed type of hemorrhage. Or it can bleed out. This is the revealed type of hemorrhage. So, in concealed, the problem is that blood is collecting but it is not visible outside. So, sometimes it can be missed. Apart from this, the thromboplastin that collects here can be released into systemic circulation. So, this is the most dangerous type of abruption. So, which is more dangerous? Is it concealed, revealed or mixed? That is a combination of two. It is concealed is more dangerous. Concealed is more dangerous. Along with that, as the blood collects inside, the uterine fundal height may appear more than that of period of gestation. So, let's see those features. So, you can fill the column which we had left out last time. So, we have already discussed about placenta previa. So, in abruption, the bleeding is going to be painful. Yes. And in this, the symptoms will not be proportionate to the blood loss because the blood is going to collect inside and the symptoms would be more, but we don't see that much bleeding outside. So, the symptoms are disproportionate to the blood loss. It is disproportionate. And the bleeding is dark colored, altered bleeding that is seen here. It is dark, altered type of bleeding because of the collected blood. So, whereas in placenta previa, it was fresh, bright color. Here, it is dark and altered type of bleeding. Uterus. In uterus, the tone of the uterus is usually increased. The tone is increased. The uterus can develop contractions as well. There could be contractions. The tone is increased. The fundal height, as I told you, would be more than the period of gestation. The fetal distress develops way early. Usually, we can see fetal distress early. Also, the complications are more. Complications such as DIC and fetal death even can be seen. Maternal complication and fetal complications are going to be there. I told you in placenta previa, it is usually causeless. Whereas, in case of abruption, there can be some associated cause such as trauma or PIH. So the patient can have PIH or there could be history of trauma before this bleeding, whereas it is causeless bleeding in placenta previa. So once you rule out that the patient is not having any placenta previa, you can go for a pervaginal examination. PV can be done after ruling out placenta previa. Yes. Now coming to the investigation, as for diagnosis, this is a clinical diagnosis. It is a clinical diagnosis. The main problem with the scan is that sometimes the fresh bleeding might not be detected by the scan. It can appear very similar to that of placenta. So usually the scan does not give us much information. Sometimes it can be seen, sometimes it's not seen. The diagnosis is primarily clinical. Coming to the management. There is no role of conservative management in case of abruptio placentae. Always it is definitive management. That is, we have to deliver the patient. We are going to deliver the patient. So, delivery is the dictum in case of abruption, whereas conservative management is the dictum in case of placenta previa. Alright. So, now let's quickly see the risk factors that are associated. So, previous history of abruption is again a risk factor here. Increased age and parity are a risk factor, just like placenta previa. Habits such as smoking is a risk factor. Apart from that, here there is a unique risk factor, that is cocaine use is also implicated in abruptio placentae. This was not seen in case of placenta previa. Any history of trauma, as I told you, antecedent events such as trauma, preeclampsia is a risk factor. Any history of thrombophilias such as antiphospholipid antibody syndrome is a risk factor. Polyhydramnios, PPROM are a risk factor, because when there is excess amount of fluid, when there is excess liquor, when the liquor drains out suddenly, there is going to be sudden decompression. And when such sudden decompression happens, there is a chance that the placenta can actually separate from there. So, polyhydramnios, PPROM is a risk factor. Similarly, multiple pregnancy is also a risk factor. The uterus is more distended. During the decompression, there is chance that the placenta can separate. Alright. Single uterine artery is also another risk factor. So, there is a classification known as the Page's classification. We saw the Brownie's classification in placenta previa. Here, basically, there are 0, 1, 2 and 3. So, 0, basically, we don't have any symptoms or signs. It is a retrospective diagnosis. Retrospective. After we delivered the baby, we had a look at the placenta and we saw that there was a clot. There was a clot seen over the placenta. That is retrospective diagnosis, or there is just a retroplacental clot with no other clinical features. This is grade 0. Now, grade 1 means there is an abruption and there is some amount of bleeding. There is bleeding PV, but the mother is alright and the fetus is alright. There is no fetal distress, there is no maternal complication. No maternal or fetal complication. Third one, there is bleeding PV. Along with that, there is fetal complication. There is fetal complication such as distress or intrauterine death. Finally, in grade 3, there can be associated maternal complication as well. The person can go into shock or there could be DIC. There could be DIC. This is basically the Page's classification. So, just write 0, M, F, both are alright. Next one, F is not okay. Next one, M is not okay. Fetus is not okay. Mother is not okay. So, this will help you to easily remember this. Alright. So, can you diagnose what is shown here? So, you can see the placenta here and you can see that there is a large clot which is occupying. So, this is an image showing abruption. So, if I give you a clinical scenario here that there is a patient who had delivered normally and when I examined the placenta, I got to see this finding. She did not have any complication at all. What is the grade of abruption? It is grade 0. This is a retrospective diagnosis. It is grade 0 if she is not having any symptoms and it is just a retrospective diagnosis while we examine the placenta. Alright. So, what is the image that is shown here? The image that is shown here is known as Couvelaire uterus. It is Couvelaire uterus. Couvelaire uterus is basically when there is bleeding and this bleeding gradually seeps into the myometrium till the serosa. So, suppose this was the uterus and here we have the placenta. So there was some amount of bleeding here and it has seeped into the myometrium and it has reached till the serosa, and that gives this appearance to the uterus. So the complication that is associated with it is, because of this, the uterus will not be able to contract properly. The uterus is unable to contract properly. There can be PPH. The uterus seems so black, right? Do we need to remove the uterus? Is it a necrotic uterus? Absolutely not. Couvelaire uterus is not an indication for hysterectomy. Be sure of the fact that in couvelaire uterus, it is not an indication for hysterectomy. We just have to control the PPH and conservatively and just close the abdomen, and it will automatically get resolved later on. Alright. So now finally coming to the management. Alright. So the management is definitive. That is, it is going to be delivery of the baby. So similar to the placenta previa, it can be either through vaginal delivery or through cesarean section. So we can go for a vaginal delivery here if the cervix is favorable. If the cervix is favorable, we can go for a vaginal delivery. In that case, we will go for an amniotomy initially. We will go for an amniotomy, and following the amniotomy, afterwards, you can go for oxytocin infusion. So if they are giving you, what are you going to do next? So the first thing is amniotomy. Next, if the amniotomy is not given in the option, then only go for oxytocin. Sometimes in the question, already amniotomy might have been done. So in that case, go for oxytocin. Amniotomy means ARM, that is artificial rupture of membranes. Alright. But in between, if there is some form of hemodynamic instability, if there is, as for the mother, there is hemodynamic instability, if she has DIC, if there is shock, or if there is fetal distress, then go for cesarean section. Please understand that even if the fetus is dead, but there is maternal distress, we will have to do a cesarean section. So, if there is fetal distress, go for cesarean section. If there is maternal problem such as instability, if there is DIC, go for cesarean section. If the fetus is already dead, but still there is maternal problems or instability, go for cesarean section. If the cervix is unfavorable, if it is totally unfavorable, then you will go for cesarean section. This is the gist of the topic antepartum hemorrhage. I hope by the end of this video, you will be able to answer all the clinical questions that is going to come from this topic. Thank you.